In an abdominal short case, do not start with a long list of diagnoses. First, identify the dominant abdominal finding. Is it hepatomegaly, hepatosplenomegaly, isolated splenomegaly, ascites, a palpable kidney, or clues such as scars, veins, stomas, and lymph nodes? Once you know the main sign, link it with extra abdominal clues. Decide the likely diagnostic group, and then confirm it with focused investigations. When the liver is enlarged, describe it before diagnosing it. Comment on size, liver span, edge, surface, consistency, tenderness, pulsatility, and whether there is associated splenomegaly or ascites. A tender, smooth liver may suggest hepatitis, congestion, abscess, biliary disease, or Budd-Chiari syndrome. A firm, irregular liver suggests cirrhosis or malignancy. A smooth, non-tender liver may suggest metabolic dysfunction-associated steatotic liver disease, MASLD, alcohol-related liver disease, chronic hepatitis, or infiltrative disease. A pulsatile liver with raised jugular venous pressure points toward tricuspid regurgitation or congestive hepatopathy. After recognizing liver disease, search for the cause. Obesity, diabetes, hypertension, and dyslipidemia suggest MASLD. Parotid enlargement, Dupuytren contracture, and neuropathy suggest alcohol-related disease. Tattoos, transfusion history, injection exposure, or high-risk history raise concern for viral hepatitis. Pruritus, scratch marks, xanthelasma, Zika symptoms, or thyroid disease suggest autoimmune or cholestatic liver disease, including primary biliary cholangitis. Pigmentation, diabetes, arthropathy, tremor, or neuropsychiatric signs should make you consider hemochromatosis or Wilson disease. If you find isolated splenomegaly, first confirm that it is truly the spleen. The spleen arises from the left upper quadrant, moves inferomedially, may have a notch, is dull to percussion, you cannot get above it, and it is usually not palatable. Then think in groups: portal hypertension, hematologic disease, chronic infection, autoimmune or inflammatory disease, and infiltrative disease. Massive splenomegaly has a focused differential: chronic myeloid leukemia, myelofibrosis, lymphoma, chronic malaria, visceral leishmaniasis, thalassemia, and Gaucher disease. When a ascites is present, confirm it clinically with flank fullness, shifting dullness, and fluid thrill if tense. Use ultrasound if the finding is uncertain. Then classify the likely cause: portal hypertensive. Ascites is supported by chronic liver disease signs, splenomegaly, and collaterals. Cardiac or constrictive ascites is suggested by raised jugular venous pressure, edema, and a pulsatile liver. Renal or nephrotic causes give generalized edema and proteinuria. Tuberculous or malignant ascites may present with fever, weight loss, abdominal pain, or lymph nodes. Painful hepatomegaly with ascites should make you think of Budd-Chiari syndrome. The key safety pearl is simple: new-onset ascites needs diagnostic paracentesis if fluid is accessible. For a palpable renal mass, describe the side, size, surface, tenderness, palatability, movement with respiration, and whether you can get above it. Bilateral palpable kidneys suggest autosomal dominant polycystic kidney disease or bilateral hydronephrosis. A unilateral renal mass may be hydronephrosis, renal cell carcinoma, pyonephrosis, or a large renal cyst. An iliac fossa mass may be a renal transplant. The bedside pearl is simple: a kidney is usually palatable, while a spleen is usually not. Finally, never finish the abdominal examination at the abdomen. Look at the hands for clubbing, leukonychia, palmar erythema, and asterixis. Look at the eyes and face for pallor, jaundice, xanthelasma, and parotid enlargement. Check the neck for jugular venous pressure and lymph nodes. Look at the chest for spider navy, gynecomastia, and dilated veins, and the legs for edema and scratch marks. A strong presentation follows one order: finding, clues, diagnostic group, and confirmation.